Hello, and welcome to our virtual CRNA Clinical Preceptorship Workshop. We greatly appreciate your time and willingness to enhance your clinical preceptor depth of knowledge. The following presentation was inspired by current literature and best practices in nurse anesthesia clinical precepting. The presentation is self-paced and can be paused and restarted at any time. The estimated time for completion is 30 minutes. We also want to thank you for participating in our doctoral project. At the end of the presentation, there is a link that will take you to our post-survey. We welcome your feedback and suggestions to improve clinical preceptor training in the future. The following topics included in this presentation were repeatedly referenced and described in current preceptor literature. The topics are applicable to not only nurse anesthesia clinical training, but have also been described in various other healthcare professions, as well as outside the realm of healthcare. In this presentation, we will provide a brief introduction to each topic, and we will describe how it can be applied to nurse anesthesia clinical precepting. The best way to start a conversation about clinical precepting is to define what a preceptor actually is, by reviewing the roles and responsibilities of the clinical preceptor. This is not as simple as it may sound. As practiced clinical preceptors, you may have transformed your own definition of this role multiple times throughout your career. The Council on Accreditation of Nurse Anesthesia Educational Programs, or COA, provides a brief description of the roles and responsibilities. The Student Registered Nurse Anesthetist, or SRNA, may only be supervised by a CRNA or anesthesiologist, and this must be done in either a 1-to-1 or 2-to-1 ratio. If a preceptor is supervising more than one SRNA, the student's abilities, the preceptor's abilities, and the patient's complexity and physical status should be considered. The preceptor should be immediately available for consultation. The COA also lists the responsibilities of a preceptor, which include providing direct guidance, evaluating student performance, and approving the student's anesthetic plan of care. The roles and responsibilities provided by the COA are concise and do not delve into specific instructions on how to precept. This allows for flexibility, but also leaves a lot of room for individual interpretation, which can lead to frustration and burnout when the role is not explicitly defined. These COA standards may not have been a focus for your previous preceptor practice. If so, you're not alone. A study investigating an alternative clinical preceptor training course revealed that participants were only slightly or somewhat familiar with these COA standards. It is, however, helpful to view the COA standards as a foundation to your clinical preceptor practice. This leads us to answer the questions, what is the goal of clinical education, and what is the role of the preceptor in this process? Clinical training is a significant component in the development and education of all future healthcare providers. Preceptorship specifically has been at its foundation for many years. Preceptorship is a learning and teaching model in which experienced healthcare providers guide students in applying their didactic learning and developing their skills and confidence in the clinical practice setting. The responsibilities of a preceptor include teaching, role modeling, creating a safe learning environment, and providing constructive feedback. Some of the barriers to precepting adult learners include lack of training on teaching methods and communication skills, production demands, and time commitment. The goal of clinical education is to transform knowledgeable SRNAs into safe and effective anesthesia providers. The SRNA perspective is an important viewpoint to consider when building your preceptor framework. Everyone listening to this presentation was once an SRNA and most likely used that experience to shape their current clinical preceptor practice. On a more universal scale, a survey from 2011 had over 600 SRNAs rank the most important qualities of clinical preceptors. Listed on this slide are the top 8 themes ranked as highly important by SRNAs. From this survey, it can be concluded that CRNAs appreciate preceptors that are invested in their role and those that are skilled and effective in non-threatening communication. It is also important to note that the CRNAs surveyed also ranked clinical preceptors as the most important factor to their entire anesthesia education, beating out simulations, experiencing unique cases, and surprisingly, the classic anesthesia textbooks. One of the challenges faced by nurse anesthesia clinical preceptors is learning how to accommodate adult learners. Knoll's adult learning theory is repeatedly referenced throughout preceptor and education literature for healthcare and non-healthcare professions. It can be universally applied and is also fitting for the SRNA-CRNA relationship. Malcolm Knowles was the original creator of the Knowles adult learning theory. Before its conception, adult curriculums were modeled after educational programs used to teach children. Malcolm Knowles was an expert in adult education and first created assumptions about adult learners that differentiated them from their child counterparts. These assumptions have been adopted and adapted a few times throughout the years. The adult learning theory now consists of 6 key assumptions. First is the idea of self-concept. Adult learners are self-directed, autonomous, and independent. This is in steep contrast to our days spent in elementary school where scheduled activities led us through the day. The second assumption is the role of experience. Adults learn by drawing from or connecting to previous experiences. While the differences in anesthesia and ICU experience are often highlighted, the SRNA is particularly primed to exploit this assumption in that they can draw from and connect their current anesthesia education to their previous ICU experiences. This should be capitalized on as often as possible. The third assumption is the adult learner's readiness to learn. The adult learner is only ready to learn what they deem as important. Life experience teaches us that there is too much information to process efficiently. This leads us to prioritize important information and ignore extraneous data. This is helpful in most cases, but can be maladaptive for the learner who often mistakenly labels important information as extraneous. The preceptor has the opportunity to guide the adult learner in deciding which information to focus on and what to ignore. If an SRNA appears disinterested in an important topic, it's helpful to tie a reason behind its importance. Examples include providing the student with an impactful personal patient experience or using the statement, "This was on my boards." The fourth assumption is that the adult learner's orientation to learning is problem-centered, task-oriented, and life-focused. Adult learners are more interested in learning things that will aid them in solving problems and performing tasks, like intubating and how to troubleshoot the anesthesia machine, rather than arbitrary facts like the name of the man who created the first LMA. The fifth assumption is that adult learners are internally motivated compared to externally motivated. External motivators can still be effective for adult learners, but the majority of their motivation is internal. This means that motivation must come from the SRNA, and while it can be encouraged and guided by the preceptor, it is the responsibility of the SRNA to maintain their own motivation for learning. The sixth and final assumption ties back to the adult learner's readiness to learn. They often need to know the value and reason behind needing to learn a topic. As mentioned, adults are tired, and SRNAs are often exhausted and overwhelmed. Anything that can be deemed as unnecessary is moved to the bottom of their priority list. As a preceptor, you can aid the SRNA in prioritizing their focus. For Michael Knowles' adult learning theory to be useful in practice, adult learning experts have created application recommendations. These recommendations include creating a conducive learning environment, involving the learner in mutual planning and diagnosing their own learning needs, encouraging the learner to formulate their own learning objectives and to identify resources, and including the learner in the evaluation process. These are all common occurrences in current clinical preceptor practice. Examples include reviewing the SRNA's anesthetic plan for the day, asking the SRNA what they want to work on at the beginning of the day, and by asking them how they feel they did at the end of the day. These simple questions allow the learner to identify their learning needs and also provide them the opportunity to evaluate their own performance. One of the more difficult recommendations to apply in nurse anesthesia clinical training is creating a physically and psychologically conducive environment to learning. The OR environment is often the opposite of that. It can be an intimidating, fast-paced, unfamiliar environment, especially for SRNAs early on in clinical training. It takes great skill to make an OR less intimidating to a new learner, but it can be done with simple steps like introducing SRNA to OR staff and supporting them in learning new skills. When the learner feels threatened and unsafe, their priority shifts from performance to survival. Learning is decreased when adult learners are in survival mode. By creating a conducive learning environment, the preceptor has allowed the SRNA to focus on learning and not just survival. Another important aspect of adult learning theory is that each adult learner is unique. They have lived different lives and have different experiences, backgrounds, and attitudes from each other. Being as considerate, patient, and culturally sensitive with students as we are with our patients and our other colleagues is important. Unfortunately, people do not present themselves with a list of wants and needs, and it will not be inherently obvious what teaching methods are best for each learner. For this reason, it's important to involve the learner by asking the learner specific questions. Some good questions to start with are, how do you learn best? What are your goals for the day? Is there anything specific I can do to help you accomplish your learning goals? What are your strengths and what are your weaknesses? After assessing the learner, it can be helpful to employ appropriate teaching methods based on the learner's needs. SRNAs early on in training have only seen induction performed on a mannequin, and modeling a proper induction sequence on a real human in an actual OR may be the best way to start their day. Coaching requires the student to have baseline context. This teaching method is very helpful in the transition from performing skills in simulation to performing skills in clinical. Prompting and cueing are helpful in teaching SRNAs to perfect their clinical skills. Also, they can be used in critical thinking scenarios by making indirect suggestions that will aid the SRNA to shift their focus away from distractors and focus on important information to make effective clinical decisions. Case presentation is also a very useful method. Having the student present the information will allow the preceptor to identify gaps in understanding and missing context. Case presentation is also a great tool to use to expand on the learning opportunities of the day. For example, discussing the presentation of possible complications during a routine laparoscopic case. The crowd favorite of direct questioning is another tried and true teaching method in clinical training. While pimping has been reported as a negative experience for trainees, direct questioning should not be avoided by preceptors. Asking direct questions and having the SRNA recall information allows them to gain confidence in what they do know and helps them identify areas that they need to review. Each of these teaching methods is useful at certain points in clinical training. The Dreyfus model of skill acquisition was first described in 1980. It describes 5 stages that learners progress through when learning a new skill. The original model was created by observing people learning how to play chess. It's been universally applied to learning all sorts of skills and will most likely look familiar. The 5 stages that Dreyfus described are novice, advanced beginner, competent, proficient, and expert. Generally, while progressing through these stages, learners will begin by relying on rules for making their decisions, and later will rely on intuition. The learner will also go from being overwhelmed from considering everything, but through experience will learn prioritization and develop a relevant focus. This model applies directly to skills, but can also be considered during the development of critical decision making. Since the model focuses on specific skills, it is possible for an CRNA to be at different levels for different skills. For example, being competent at induction but being an advanced beginner at emergence. Being able to identify a learner's skill level is not only helpful for proper evaluation, but can also help determine which teaching method is appropriate to employ. The first level of skill acquisition is novice. These learners are completely rule-based and lack real-life context to apply to their textbook knowledge. They rely heavily on analytic reasoning, but often cannot make correct decisions because they lack situational knowledge and context. An example is knowing that the Mac blade needs to go into the vallecula to achieve a glottic view, but lacking the experience to know how to redirect the blade into the optimal position. Novice clinical learners do not necessarily have a lack of knowledge, just a lack of context. The novice learner needs an experienced provider to help them organize their knowledge by pointing out meaningful findings and eliminating irrelevant information. In skill acquisition, this is best done by modeling proper form and coaching by providing direct, timely feedback. An advanced beginner has now gained context and is beginning to understand its importance, but they are still heavily analytical and revert to their textbook knowledge when unable to accomplish a goal. In skill acquisition, this can look like an CRNA who is able to intubate when the patient is properly positioned, but falls short when troubleshooting is needed to improve the glottic view. They still need assistance when it comes to identifying important versus irrelevant information. Interestingly, expert providers may not be able to explain their reasoning for clinical decisions to the advanced beginner, because the expert relies on intuition and pattern recognition that is difficult to translate to the analytical thinking process of the advanced beginner. Oftentimes, near-peer mentoring can be helpful as competent and proficient providers will be able to provide their analytical reasoning to the advanced beginner. CRNAs should be encouraged to discuss their clinical progress with upperclassmen or newly graduated CRNAs, as well as with expert providers. Competent learners are aware of context and have acquired a decent amount of experience, but they still rely on their analytic foundation. They can handle routine scenarios with small variations and complications, but are unable to efficiently manage complex patients or cases. Complexity may lead to exhaustion, as they tend to be overly analytical. Competent learners should be provided with a balance of autonomy and supervision. Complete autonomy at this stage may cause the learner to enter survival mode and revert to advanced beginner tendencies. The CRNA should be given the opportunity to carry out their own anesthetic plans safely and should be held accountable for their decisions. This allows them to develop confidence in their practice, but the balance of supervision and guidance is important, especially in complex cases. CRNAs are striving throughout their years of clinical training to become proficient anesthesia providers before they are tasked with being independent CRNAs. Proficient learners are no longer as dependent on analytical reasoning as competent learners, even in complex cases. Their experience allows them to develop situational discrimination and pattern recognition that they use to make decisions, and they are now comfortable managing evolving situations. While they have gained comfort in complex scenarios, they should not be constantly exposed to complexity. They still need a balance between routine cases and complex cases. Managing routine cases allows them to develop trust in their intuition, while the occasional exposure to complexity ensures that they are aware of their weaknesses and inabilities. The proficient learner should be mentored by an expert to prevent complacency. Experts are the CRNAs we choose to care for our own family members. They act immediately based on experience and are mindful of their own limitations. This allows them to ask for help from other experts when needed. No one is an expert in everything. It is important for experts to seek out challenging situations and continue to learn new skills to avoid complacency. While SRNAs rarely achieve this expert level in clinical skills during training, they should be expert learners and be attuned to their own strengths and limitations. Commonly, SRNAs are classified as juniors or seniors in clinical training. It may be expected that juniors are novices and advanced beginners, while seniors are competent and proficient. However, clinical training is far from a linear process, and it's important to look below the surface at each clinical skill when evaluating a learner's skill level. Skill level varies depending on the type of skill, and different learners may progress at different paces. In reality, an SRNA may go from being competent to a novice and back to being competent again in the same day, depending on the case complexity and clinical skills required. Providing feedback and giving constructive criticism can be a daunting task, but it's an essential skill for preceptors to have. A survey of SRNAs and CRNAs in 2017 ranked debriefing as the #1 area of importance in clinical education, but it also found that formal debriefing occurred less than 50% of the time. In this section, we'll discuss the barriers that have led to decreased debriefing in the clinical setting and provide some tools that can be used to overcome those barriers. As we mentioned in the last section, clinical learning rarely fits into a linear progression. Debriefing is a crucial step in the feedback loop that drives clinical learning. It's done to identify gaps in knowledge and skill. The first barrier we can discuss is the timing of debriefing. Ideally, this would occur throughout the day after each case or significant event and at the end of the day. However, production pressure in the fast-paced environment of the OR inhibits us from providing real-time feedback and having these multiple debriefing sessions in a clinical day. Another barrier is the lack of privacy in the OR. Ideally, feedback and debriefing would occur in a private, quiet location, which can be difficult to find or create in the OR. There are multiple debriefing tools that can be used to alleviate these barriers, but not eliminate them entirely. We'll review 3 of these debriefing tools, which will help debriefing sessions expand beyond the initial question of, how do you think you did today? The first debriefing tool is founded in simplicity. Pendleton created this feedback model that first focuses on the positives and then shifts to the improvements. This method allows the learner to expand upon their own interpretation of events while also allowing the preceptor to provide constructive criticism. The preceptor will first ask the learner what went well, and then add to the learner's perspective with their own observations. Next, the learner has the opportunity to share what could be improved, which allows the preceptor to assess if the learner is self-aware before they provide criticisms. This debriefing tool is simple, easily remembered, and it can be initiated by the preceptor at any point throughout the clinical day, or it can be used during the end-of-day debriefing session. The next debriefing tool is the 1-minute preceptor model, which is supported by literature as an effective and preferred teaching model by preceptors and learners in clinical training to become nurse practitioners and medical doctors. It focuses on 5 steps and is best used to encourage critical thinking, reinforce positive performance, and correct negative performance. The first step is to get a commitment from the learner. This can be done by asking what the learner thinks is going on with the patient. Next, the preceptor should probe for evidence by asking how the learner came to that conclusion and what other conditions they considered. The third step is to teach a general rule, followed by reinforcing what was done well and correcting mistakes. For example, the end tidal CO2 is low in the operating room following induction. The SRNA can be prompted to list reasons for low end tidal CO2. They can then be prompted to think through each reason they listed and correlate them to the patient's current status. The general rule can then be taught that low end tidal CO2 following induction is most commonly seen due to hypotension. After the rule is taught, the student can be praised for their analytical thinking and encouraged to apply the general rule in future practice. Another tool that can be used to coach a learner's critical thinking or to debrief after a significant event is MAP, First, the learner is encouraged to seek out missing relevant information and probed for what they think happened or is going on with the patient. Next, the learner should be encouraged to anticipate and think through what may happen next. This can be prompted by asking, "What would you like to see happen now, and how can you facilitate that happening?" The last step is prioritization. Now that the correct steps have been identified, it is important to identify what needs to be done first. Oftentimes in anesthesia, the patient condition requires quick action, and even a 1-minute preceptor model or quick map run through is too much time wasted before acting. In these scenarios, the questions become past tense after the patient is stabilized. In clinical practice, SRNA-CRNA communication is a mixture of real-time feedback and past tense debriefing. Both are important in aiding the clinical learning process. This concludes our presentation on nurse anesthesia clinical precepting. We hope that you found this information helpful and applicable to your own practice as clinical preceptors. We'll end with key points from this presentation. First, adult learners are self-directed, internally motivated, and need to know the value of what is being taught. Second, it's important to teach to the learner's skill level, whether they are an expert or a novice. Lastly, the use of a debriefing tool can help preceptors and learners identify gaps in knowledge and skills. We want to thank you for taking the time to complete the Preceptorship workshop. We have included references for the information provided in this presentation at the end of this video. We also want to thank you for participating in our doctoral project. Please complete the post survey at the link in the video description below. Your feedback and suggestions will be used to improve future preceptor training courses. Please reach out to us with any additional questions or suggestions.